everyone, and welcome to the webinar today. My name is Greg Wahlstrom, and welcome to the Healthcare Executive Webinar Course, Population Health Management, Managing Seriously Ill Populations to Achieve Triple Aim. We are pleased Bayda Home Health, MedStar Shah Medical Group, and Southeastern Regional Medical Center experts to collaborate around such an important topic. We would like to especially thank Dr. Mandeep Mangat for her continued support with our Population Health Division at the Healthcare Executive. After today's webinar, you'll be directed to a short survey, which we hope you will take the time to fill out. If any IT problems arise, please visit support.anymeeting.com for further assistance. As we begin the presentation, can you please mute your telephone lines until the question and answer portion of the event. On the left-hand side of the webinar platform screen is a text box to write a question to the presenters. If you have a general question, please insert your question into the text box. If you have a specific question for one of the presenters that you would like to ask, please insert his or her name next to your question. Just as a reminder, this webinar is being recorded. We are happy to announce that there are a vast amount of attendees who are listening here in the United States and abroad. Like I said, my name is Greg Wahlstrom, and I will be your guide for today's discussion. A little bit about palliative care. Palliative care is an interdisciplinary medical specialty that focuses on preventing and relieving suffering and supporting the best possible quality of life for patients and their families facing serious illness. This program will provide a rationale for palliative care services, and it will also provide an update on current and proposed models of palliative care delivery. Some of the topics we will discuss: provide a rationale for palliative care and its role in continuum of care for seriously ill patients, differences between palliative and hospice care, core components of palliative care, understanding palliative care services, goals of care, psychosocial support, coordination of care, as well as identification of patients appropriate for palliative care, the role of effective public engagement to improve palliative care for serious illness management, care transition and reducing readmission within palliative care, modern healthcare challenges in managing seriously ill patients, palliative care and achieving triple aim, current and proposed models of care, hospital-based palliative care, non-hospital-based palliative care services, as well as hospice model of palliative care. And finally, successful palliative care program. Today's moderator, Greg Wahlstrom, MBA, ADM, President and CEO of the Healthcare Executive. Greg Wahlstrom is a results-oriented senior healthcare executive with more than 17 years of broad background in business, healthcare, and human services, and has an extensive operational and administrative expertise. He is currently the President and Chief Executive Officer of the Healthcare Executive, leading organizational performance assessment, multiple program areas, followed up with customized C-suite healthcare executive training that speaks to identified needs. Greg has delivered focused programming around key elements to achieve success based upon best practices and emerging best practices that show promise of improving healthcare organizations nationally and internationally. He has led webinars and face-to-face webinars for thousands of healthcare administrators and executives through the American College of Healthcare Executives. And prior to the Healthcare Executive, Greg worked as an assistant administrator, director of social services, and as a behavioral health case manager. Greg received a master's degree in business administration and healthcare management and a bachelor's degree in business administration from the University of Phoenix. He has also completed studies abroad at Shanghai University in Shanghai, China, and he is a member of the American College of Healthcare Executives and is also the current immediate past chair of the Healthcare Executive Education Committee for the Central Illinois chapter of the American College of Healthcare Executives. Our second presenter, Dr. Mandeep Mangat, MD, MPH, Senior Administrator, Population Health Management and Clinical Integration, Bayda Home Health Healthcare. Mandeep K. Mangat, MD, MPH, is the Senior Administrator of Population Health Management at Bayda Home Health Practice. She directs the ongoing development and implementation and coordination of population health initiatives aimed at enhancing quality of care and clinical outcomes at the system level. Prior to joining the position in 2014, she worked as a physician, public health professional, and as the director of general medicine department in acute care setting. She has over 14 years of extensive healthcare experience in hospital medicine, home health, clinical operations, population health, and operational efficiency improvement in both national and international settings. Her interests include outcomes management, results-driven continuous improvement, and multi-level determinants of population health. She received her medical degree, MD, from St. Petersburg Medical Academy, her master's degree in public health, MPH degree, with a focus in healthcare administration from Westchester University, and a Lean Six Sigma Healthcare Process Improvement Master's Certification, LSS, from Villanova University. And our final presenter today, Vicky, Parikh, Executive Director, Population Health, MedStar Shah Medical Group. Dr. Vicky Parikh is a results-oriented health healthcare executive with more than 10 years of experience who combines clinical, population health, public health, clinical research, and data management knowledge to transform healthcare systems and improve care delivery and quality. He is currently the Executive Director of Population Health and Clinical Research at MedStar Shah Medical Group, responsible for the overall strategic direction and coordination of all population health initiatives, including ACO, PCMH, MMPP, Million Heart, Care Management, Chronic Disease Management Programs, Quality Improvement, and Outcome Components. As Executive Director of the Reliance Health, Vicky has successfully led formation and implementation of 5 accountable care organizations, ACO, in 12 counties in Maryland, 4 counties in Virginia, and District of Columbia, with independent private practice collaborating to achieve the triple aim for 60,000 Medicare beneficiaries. Vicky has received his master's degree in public health from George Washington University. He also received his medical degrees at Mumbai University in Mumbai, India, and worked in ICU at Bombay Hospital in a tertiary care setting. He is a member of the American College of Healthcare Executives, ACHE, and Vicky is also a member of the Maryland State Health Information Advisory Panel and Maryland State Practice Transformation Committee. Now I'd like to pass the floor over to my colleague, Dr. Mandeep Mangat. Good afternoon, Dr. Mangat.
Thank you, Greg, for the introduction. Welcome to all of you who are viewing the program. I have been asked to discuss with you the rationale for palliative care and describe its role in the continuum of care for seriously ill patients. So we'll start off with the poll question. Does your organization provide palliative care service? We'll wait until the poll fills up. So the results are in. 62% of you say that your organization provides palliative care services. That's remarkable. 5 years ago, there were almost no palliative care programs in the United States. The first ever state-by-state report card on end-of-life care, which was released by the National Organization last Act, points up to this positive trend. Today, approximately 700 hospitals nationwide offer some type of palliative care program, and slightly over 2,000 report offering pain management services. And this is an enormous accomplishment, but we still have a long way to go. If we consider the fact that the sickest of 10% of the U.S. population accounts for 64% of healthcare costs, most people facing serious illness will end up in the hospital at some point. Multiple reports have shown that patients with a serious illness and their families don't receive the quality of care that they deserve. Studies have demonstrated that these patients and their families receive poor quality medical care and report untreated symptoms and unmet psychosocial as well as personal care needs. Complex patients and caregivers want a voice in their care. They want more control. Their families want clear, ongoing communication about what to expect and how to plan their treatment. Pain is the most common and widely feared symptom in these patients, and they want support for their caregivers and a sense of safety in healthcare system. In a nutshell, people facing serious illness really want the type of service that palliative care can provide. If we look at the cost savings with palliative care program, we notice that in various studies, on average, palliative care consultation is associated with reductions of $1,700 per admission for live discharges and $4,900 per admission for patients who died in the hospital, amounting to savings of more than $1.3 million for a 300-bed community hospital and $2.5 million for the average medical center. So palliative care has been shown to lower costs for hospitals and payers. It requires low startup investment and provides a clear and effective system of care for outlier patients by matching them to optimal care settings. Palliative care consults not only save money, but they have been associated with reductions in symptoms, high family satisfaction with overall care, and greater emotional support when compared with usual care. Studies show that palliative care teams increase the rate of hospice referral for patients whose disease is non-responsive to curative intervention. So palliative care is specialized medical care for people with serious illness. The goal of palliative care is to prevent and relieve suffering and to support the best possible quality of life for patients and their families, regardless of the stage of disease or the need for other therapy. It can be provided along with other medical treatments and life-prolonging care, or it could be provided as the main focus of care. So palliative care is appropriate to those suffering with cancer, heart conditions, liver failure, renal failure, and a number of other conditions. Palliative care is medical care which is provided by interdisciplinary teams and it includes the professions of medicine, nursing, social work, counseling, nutrition, rehabilitation, therapy, and other healthcare professions. It is appropriate at any age for any diagnosis at any stage in serious illness. So in palliative care field, there are three types of patients. Those with curable diseases, such as a patient who is 90 years old, has leukemia, who received a bone marrow transplant with 70% success rate, or someone who has a serious illness such as Alzheimer's disease that may last for decades, and those with progressive incurable diseases such as metastatic cancer. All three groups of patients can benefit from palliative care. There is often a lot of confusion regarding the difference between palliative care and hospice. I think this graphic makes it easier to understand. It was presented at a Mayo conference I was in last week. So think of palliative care as the overarching care umbrella. Hospice is one type of care or one subset of palliative care under the palliative umbrella. So the differences are that palliative care can be provided anywhere in the disease trajectory, from the point of diagnosis through the death, while hospice focuses on care for life-limited patients in their final months life. Palliative care blends curative, life-prolonging treatments and comfort care, while hospice offers the most intense comfort care. Hospice care is palliative by nature. The illness, however, with hospice patients has progressed to a point where curative treatment is no longer desired or beneficial. Hospice care supports the patient and their families while focusing on relieving symptoms and offering comfort from symptoms such as pain, shortness of breath, fatigue, nausea, anxiety, insomnia. Treatments are not limited with palliative care. So the treatments can range from conservative treatments to aggressive curative treatments. Hospice care treatments are limited, and they focus on palliation of symptoms. The goal is no longer to cure with hospice, but to promote comfort. Healthcare professionals often perceive that palliative care referral is appropriate only when the patient is dying. This limitation excludes majority of patients who are not dying but have poorly controlled symptoms and distress that could lead to abrupt transition of care from curative to palliative. Palliative care referral is best initiated early, often at the time of diagnosis. Ongoing palliative care input can be provided according to the needs, and this way a smooth transition from curative to palliative is facilitated. So let's look at a case study. It's from Baylor University Medical Center. So 42-year-old woman, she had widely metastatic ovarian cancer, an open abdominal abscess, renal failure. She's morbidly obese and has diabetes mellitus. She had stopped eating effectively, was dependent for 5 of 6 activities of daily living. Her healthcare team understood that she had life-limiting disease and a short life expectancy. And they had been attempting to discuss with her the do not resuscitate and possible hospice evaluation. The patient and family insisted that everything be done for the patient, including the aggressive treatment. The attending at that point requested a palliative care consult. By this time, the patient had been hospitalized for 25 days, and this was her second hospitalization in 4 months. During palliative consult, patient denied pain, even though she appeared in obvious distress, and later she confessed to a pain between 6 and 8 on a 10-point scale. A multidisciplinary palliative team consisting of specially trained physician, nurse, pharmacist, social worker began to work with the patient, family, and staff. So within 48 hours of consultation, the team achieved several important goals. The patient worked through her denial. She accepted that she was dying and accepted palliative care as the primary goal. She agreed to do not resuscitate order. She was able to express a wish that she die at home in her own bed if possible. She accepted recommendations for improved pain control, and she agreed to report her symptoms to employees. She was reassured that she would not be put to sleep with pain medicine and that she could choose to accept or reject pain medication. So her pain medications were adjusted for severity of pain as well as for progressive renal failure. Although she initially refused some pain medications, she began to ask for and accept those medications as her pain got worse. As a result, her pain declined from an average of 7 to 0 on a 10-point scale. She asked for help in communicating with her family members who were in considerable denial. This was the most challenging aspect of her case. Multiple expensive and non-beneficial medications were discontinued. The patient requested spiritual comfort through baptism, which was arranged in a bedside service. The patient requested spiritual comfort for their family members as well, who continued to experience significant denial. The patient was eventually admitted to an inpatient hospice because it was felt that her care could not be adequately managed at home. This is just one of the examples of how palliative care can also become a bridge to hospice, allowing patients to think in terms of symptom relief earlier and to adapt to the idea of hospice. This table outlines differences between hospice and palliative care in the United States. So in the United States and increasingly in most countries, palliative care and hospice have very distinct meanings. Palliative care is interdisciplinary care that focuses on improving quality of life for persons of any age who are living with any serious illness and for their families. As exemplified in the case study we discussed, it treats pain, other symptoms, psychological and spiritual distress. It uses advanced communication skills to establish goals of care, and it helps match treatments to those goals. It provides an added layer of support to patients, their loved ones, and treating clinicians. So as I mentioned before, palliative care is best initiated at the time of diagnosis and is provided concurrently with all other disease-directed or curative treatments. Hospice, by contrast, is a formal system of interdisciplinary care that provides services to the dying in the last months of life. Settings for hospice care and payment mechanisms vary across the country. So in the United States, unlike most other countries, hospice is a relatively separate system of care for terminally ill. Eligibility criteria are defined by insurance benefits and federal programs such as Medicare, Medicaid, Veterans Affairs. Medicare certified hospices are subject to strict regulatory requirements. Currently, patients qualify for hospice if they have a prognosis of survival of 6 months or less and are willing to forego curative treatment. In terms of palliative care, hospital bill for inpatient days under traditional Medicare, Medicaid, or commercial insurance. Physicians bill for palliative care consultation services under Medicare Part B and commercial insurance. However, given the time-intensive nature of clinical work, billing revenue does not match program costs. Hospitals usually end up contributing 50% or more of direct funds to support palliative care programs. The investment is usually repaid through cost avoidance, as palliative care reduces unnecessary hospital stays, pharmacies, and lab costs, and the typical return on investment is between $2 to $3 saved for every dollar invested in program costs. The need for palliative care grows when people with serious and chronic conditions were living longer and needed an alternative to hospice care, which was designed for people with progressive illnesses and short prognosis. And the key is to build a comprehensive plan that integrates palliative care with traditional diagnostic tools and medical care, and that also provides symptom relief and emotional support. So in 2004, the National Consensus Project identified 8 domains as the framework for clinical practice guidelines for quality care. These domains include ethical and legal aspects where patients' goals, preferences, and choices form the basis for plan of care. The team is knowledgeable about relevant federal and state statutes and regulations. Palliative care manages physical aspects of care, pain, and other symptoms such as dyspnea, fatigue, constipation, medical diagnosis, the use of best practices. Psychological and psychiatric issues are assessed and managed. Grief and bereavement programs available to patients and families. Social aspects of care with appropriate care plans provided to patients. Spiritual concerns are assessed and addressed. Linkages to community and spiritual or religious resources are provided as appropriate. Cultural aspects of care are assessed and addressed as well. Improvement in hiring practices reflect the cultural diversity of the community that we serve. And signs and symptoms of impending death are recognized, and a hospice referral is usually recommended when the patient is willing. Best-in-class palliative care programs span the continuum to address patient needs wherever they may first be identified. In an inpatient setting, patients admitted to the hospital receive an inpatient consult or receive care from an interdisciplinary staff member prior to the discharge. So the best-in-class palliative care programs span the continuum to address the patient needs wherever they may first be identified. So in an inpatient setting, the patients admitted to the hospital usually receive an inpatient consult or receive care from an interdisciplinary staff member prior to the discharge. And palliative care services are often provided to skilled nursing facilities by an external provider, an external partner. In a home care setting, One member of a palliative care team, usually it is an NP or a social worker, visits the homebound patients with advanced illnesses to provide initial assessment of care needs, ongoing support, and care coordination with other providers and services. Patients with advanced illnesses receive palliative care consults or ongoing care in palliative care specialty clinics, which are freestanding or could be embedded in a host clinic. Services are typically subsidized by a hospital or health system, often with an expectation that the care will reduce the non-beneficial acute and emergency services, so reducing the burden on their ED. Primary care physicians are usually trained to deliver generalist palliative care, and the palliative care team may rotate through primary care clinics to assist with more complex patients in their practice. Patients can also access palliative care specialists remotely through secure video conferencing equipment in clinics or their homes, and symptoms and medical care are remotely monitored. And remote monitoring is also used in home health settings. Most health systems do develop an inpatient palliative care service before they expand to the outpatient setting. There's no single right pathway to follow. Some health systems design their outpatient expansion to first focus on a special patient population. So it could be a cancer outpatient center. Others decide a specific site of care. It could be a clinic or home. Health systems do have to consider the current market dynamics. They have to look at demand for services. Intensity of staffing resources usually increases as the referrals increase. And then we have to look at investments in facilities or equipment. And the most important part is really buy-in from the leadership and the staff of your organization when you're trying to expand your program to an outpatient setting. So there are several examples of palliative care programs and integrated delivery systems. Advanced Illness Management Program, which was developed by Sutter Health in Northern California. It connects major healthcare settings, including hospitals, physician offices, and home-based services to bridge the gap between acute care and end-of-life care for Medicare patients with late-stage chronic illness. Department of Veterans Affairs, VA, it offers home-based palliative care services to veterans as a covered benefit. Kaiser Permanente, which is another single-payer and integrated delivery system, has offered its members home-based palliative care services for years at this point. Private payers such as United Healthcare, Aetna, Blue Cross Blue Shield, they're all testing capitated payment models for community and home-based palliative care programs. So integrated health systems have financial incentives to invest in a continuum of high-quality palliative care in the community, because caring for high-risk patients in their homes and in community settings is usually much less expensive than caring for them in the ED and hospice. Thank you for your attention. I'd like to pass the floor over to the moderator, Greg Wahlstrom. Greg?
Thank you, Dr. Mangat, for sharing some pertinent information about the role of palliative care across the continuum of care. I think that healthcare professionals can become confused when referring to palliative care over hospice care. When we talk about the basic understandings of palliative care versus hospice care, is it fair to say that some healthcare professionals are not completely familiar with the difference?
So most people have heard of hospice care, and they generally have an idea of what services hospice provides. What they don't know, or what may be confusing to them, is that palliative care is care that accompanies the patient throughout their journey, from diagnosis and hope of care to hospice. So hospice is an acknowledgement that person has exhausted all medical treatments and has had enough. It is opposite of aggressive or curative modalities that are used in conventional medicine. Whereas palliative is part of hospice care, but you don't have to be dying to receive palliative care.
One other question that I had is, does palliative care professionals need special skills?
So palliative care professionals usually require the skills that are not always taught during medical school training. These skills are very critical to working with patients who have advanced illnesses. So the professionals do need rigorous training in symptom identification, management, but they also need training on how to communicate very difficult information under painful circumstances. And this is very difficult for us, and we usually avoid it. But patients need a clear understanding of what's happening with their illness and how we are planning to care for them. In addition to that, I think professionals also need to have an ability to work on a team that typically includes a physician, social worker, clergy, nurse, and all of these team members basically share the stress and responsibilities of this kind of work.
And then one final question is, what steps should a hospital take to start a palliative care program?
So there are several key steps that organizations can actually take to start palliative care teams. I wanted to point out to a great resource, which is Center to Advanced Palliative Care, CAPC, also called CAPC. It has helped many organizations start palliative care teams, and it is valuable to seek guidance from organizations such as those and avoid reinventing the whole wheel. So first of all, I think you do need to establish a system-level interdisciplinary committee or task force which has representation from leadership, physicians, financial managers, chronic disease management staff, discharge planners. And once you have established a committee, this committee would then take a task on to do some sort of needs assessment to help identify existing gaps between current and ideal clinical care. Now, they might even go ahead and gather some data on pain and symptom management, length of stay, patient and family satisfaction, or any other current problems that they are facing in their organization in terms of care of seriously ill patients. So palliative care services can also be added on as a supplement to existing offerings. So if an organization has a pain management program, palliative care services can supplement that program. So it is also, I think it's helpful to really review a lot of literature on palliative care clinical service models and see how they impact the key metrics which you are planning to impact in your organization, and then develop a financial business plan. You definitely need to codify a specific group of patients. It could be seriously ill patients at any age, diagnosis, and illness state, and then establish criteria for admission into palliative programs. And obviously, you would need a referral management system because referrals do tend to grow rapidly once you have a palliative care program in process. Most organizations would create a 1 to 5 year business plan ahead of time to accommodate for program growth and increase staffing needs.
So now I'd like to pass the floor over to Dr. Vicky Parikh, and I will pass the floor to you. Good afternoon.
Good afternoon. Thank you, Greg. Dr. Mangat has gone ahead and mentioned some very key and distinctive points about palliative care. I think one thing before I start off, I would like to say that hospice is a type of palliative care. If we can go ahead and think through it that way, it becomes easier to follow through and the rest of the things what we're talking about. And the interesting part is, before I jump onto the slides, it's the fact that what is going on with Medicare Part A as well as Part B coverage is that the hospitals are directly funding some support to the palliative care, but the ROI Dr. Mandeep was mentioning is definitely higher. The only caveat here is that when we divvy it up between the direct contribution or the direct ROI, the indirect ROI, that becomes extremely helpful. And that is what a lot of organizations have started to work in order to go ahead and see that something like what we do in transition of care from inpatient to outpatient, in similar way when we are doing the hand-holding for palliative care, can we go ahead and account for the direct benefits, but go ahead and other places we are touching. That's pretty much. With that, I think one of the key questions comes is there are key stakeholders in the equation. So it is payer, patient, and then the provider. What I would like to mention is that who are the candidates for palliative care? Which are the patients? When we are saying that palliative care is basically provided to go ahead and improve the quality of life, hopefully increasing some sort of life expectancy depending on the number of comorbidities, as well as reduce the unnecessary hospital readmits and ER. The question to be asked is that, as I mentioned on the slide, would you be surprised if this patient died in the next 2 years? If the answer is no, then most of these cases would be an appropriate candidate for palliative care. Now, this is a generalized version or simplification to go ahead and identify people who may need palliative care. The other portion is that there are a few other questions. That what is the progression of the disease? Do we need to do advanced care planning? What other stakeholders need to be involved in order to go ahead and help the patient out who's suffering from multiple things? Like he may be, I'm sure these all patients are polypharmacy patients, they have multiple comorbidity, they need nutritionist help, help from a social worker, and so forth. There is a whole paradigm and process where this candidate needs to be helped, including specialists, primary care, and merely speaking, if we look at the picture, it's basically, patient in the center and everybody surrounding the patient, as we call it in the patient-centered paradigm. Most importantly, it is being facilitated or coordinated by the palliative care provider, and I think that is a big one right there. With that, where I would like to mention is that why is it that patients are so concerned whether they can go ahead and get palliative care? What does it mean? Do I have to pay more? Is my insurance covering it? And in the forthcoming slides, I'll be discussing that. In the next slide, please, which I was just mentioning, is that how do people know about palliative care? How many people are aware about it? How do we really go ahead and talk and offer these options to patients? Not only in inpatient care settings, but even in the outpatient care setting. And the part of the problem is that the general awareness needs to be increased. We really need to go ahead and educate communities and public to go ahead and understand what is palliative care about and how helpful it is, and what is the impact of palliative care. But most importantly, they need to understand that they are the ones who are in front of the patients, and this is being done keeping in mind that how we can be patient-centered. Based upon that, I think, and there is very limited knowledge regarding. One of the key aspects is that overall, when you're even asking at the community level, like the other day I was presenting in 3 different counties and I was talking about palliative care, it seemed that even the county health departments are basically suffering from the fact of lack of knowledge, and most importantly, what is transpiring is that there is not enough to be given out to the patients or to other providers, allied providers who are in this as continuum of care stakeholders. How does palliative care help? Basically, palliative care is helping us to go ahead and close the gaps in care, definitely, because there are multiple conditions that patients are suffering from. It enables us to go ahead and carry forward the care coordination across the continent. We can formulate the care plan as we do it for other patients who are high utilizers, but this is a much more concrete / robust care planning needed, and which is shared amongst all the people who are participating to provide care for that patient. But the key thing is the communication and basically breaking out the silos where everybody is in it together as a palliative care provider is kind of ensure that they are playing the role of facilitator. The other part was that caregivers, they need to be engaged, they need to be educated, and this palliative care pyramid really helps the family to understand much more. It is not that they would be flying in the blind, they would be having a factual knowledge about what is going on with the patient or their relative and what help is being offered without them going ahead and having additional costs out of pocket. One of the key aspects is that in palliative care, as we are doing it in other models of ACOs and ACMH, is there's a collaborative effort between the palliative care providers, the inpatient care hospitals, hospice, nursing homes, home care agencies, and so forth. This really basically boils down to the fact is that how we are enabling the care coordination across the continent, but most importantly, all these different stakeholders are coming together, making sure that they are keeping the patient again in the center, providing the support what needs to be there to improve the quality of life and ensure that the patient has some control in terms of their choices as they are moving ahead. What are the current challenges, and some of it we've already underlined, but I would just reiterate that one of the key things what has happened is, or some of the key things which have happened is, that there is not enough material which is being shared for palliative care, especially in outpatient settings at community health level, and we should be utilizing all potential media, social media, etc., to really go ahead and educate the people regarding the advantages of palliative care and why it is such a supporting mechanism, so to say, for the patients who unfortunately have more than X number of conditions and are suffering and the quality of life is deteriorating. This would provide additional assistance and understanding to caregivers, because a lot of times, as we hear in the trenches while working with the patients, that the caregivers feel that they kind of don't have enough understanding or don't have enough voice, and at least in the palliative care pyramid, caregivers are really involved in a very distinct manner, as well as they are engaged so that the patient is given the best quality of care or can be provided the best quality of care. One of the things what has transpired over the period of time, I'm referring to Dr. Mangat's full question, is that there has been a solid improvement in terms of increasing awareness of palliative care, and the fact that there is evidence-based literature which is supporting the fact that palliative care is overall going ahead and helping to cut down the total costs of healthcare. So that has brought palliative care at the forefront rather than it just being attached with hospice. And this is much more than just being contained at inpatient level also. This could be provided at home. The other thing is that there needs to be a solid understanding when the patient is discharged from the hospital and there is a algorithm based upon which that okay, this patient could be good for palliative care or he is the right candidate. I think the staff needs to be trained, whether it is the inpatient coordinator or the outpatient coordinator, can go ahead and help the caregiver as well as the patients to be steered towards the fact and the resources about palliative care in the community. A lot of hospitals are doing it, but at the same time, when we are talking about collaborative efforts, nursing home, home health, outpatient care center, they all need to be involved in this. And the most crucial part in this is that, truly speaking, it is going to boil down to the fact that as far as the insurance companies are covering palliative care, currently they are covering it, but it is different in different states from Medicare. And then the second thing is Part A, there is a certain amount of coverage, and then Part B, there is X% of coverage. But for the commercial payers, it really depends on the plan. And once that aspect is taken care of, where the commercial payer is covering the palliative care, it would help immensely to go ahead and engage the physician as well as the patient, because that's the patient's first question: am I going to be covered? And in order for us to engage the patients, regardless to all the resources we provide, that is one critical aspect. And the other part is physician engagement. The reason being is that if the patient is covered and is reaping the benefits of going ahead and being a part of a certain insurance plan, what transpires is if the physician is going to suggest, as we know, patient is not going to go ahead or caregiver is not going to go ahead and give a pushback on the fact that they could be ideally candidates of palliative care, but actually go ahead and respond to that request and participate in that. So with that, I would go ahead and hand over the baton to Greg. Thank you very much for hearing me out, and Greg, thank you for giving me this opportunity.
Absolutely. Thank you for sharing, Dr. Parikh. I'm just going to interject a couple quick questions to Dr. Parikh. And, Dr. Parikh, one of the questions that I have for you is, does insurance cover palliative care or hospice care?
Yes. Insurance companies do cover palliative care, and Medicare Part A, there is a certain amount of coverage. But Medicare Part B does cover, The thing is that Medicare currently is not using the term palliative care coverage. So that's where there is some portion of the confusion. And many private insurance companies and HMOs are offering palliative care and hospice benefits for now. The part is that I don't have the breakdown that which company covers and what percentage of coverage is there, because it could be from plan to plan and state to state is what I basically have been able to assess. Same is for Medicaid.
And one other question that I wanted to ask is, as we were talking about public awareness of palliative care, and as you mentioned about 70% of people do not have any knowledge as it relates to palliative care, what do you think we as healthcare professionals can do to overcome this barrier?
I think the way we are talking about team-based care, value-based care, where we've really picked up on the fact that these are the terms which are well-known, popular, and people understand the meaning of it. I think the same thing is needed for palliative care at all levels, meaning at each level, whether it is payer, provider, patient, there needs to be enough traction gained so that one can really go ahead and take advantage of this particular paradigm or the care which can be provided to the patient. The thing what is happening right now is that there is very limited knowledge. I do not see a lot of handouts or materials or social media usage regarding palliative care, and I think that is something which we can utilize, especially downstreaming and disseminating that information at the patient level. It could be through patient portals. It could be that, okay, this is what we do and this is where it is, how it is going to help you. So a whole bit of it is going to be how we educate the patients and the physicians regarding palliative care.
One of the major barriers for patients and families in receiving palliative care in relationship to access of care and referrals provided by healthcare providers, what do you think we can do from a hospital and a managed care aspect to increase access for patients and families?
I think part of the thing is that if we can go ahead and have a separate division or like a standalone person accountable for this is what most of the systems are trying to do, if not a person where they work closely with the inpatient and outpatient coordinators to go ahead and ensure when it comes to the fact of discharge planning and based upon the patient's number of diagnoses and the candidacy for palliative care, that patient is steered towards palliative care. And I think there has to be a team or at least one person to begin with, basically to go ahead and engage those patients to participate in palliative care with offering them the understanding that what are the different pillars of support they get once they participate in the palliative care. Systems are doing that. I think there again the issue comes is that, okay, hospital as an inpatient care center is ready to do it. Hospice understands what it is about to a reasonable extent, or nursing home may understand. The gap right now is at the outpatient care center, where there is not enough, how should I say, know-how about going and tackling this program, or even having a pathway jotted out to really go ahead and do something meaningful with palliative care. And it is needed because some of it can be gone ahead and provided at home health level. Some of it can be provided at the outpatient care center level, which again does not include the facility cost, where there is only professional fees more than likely involved if there is no procedure. But the idea is that all these people need to collaborate together, and I would go back to stating that this is very similar to when we are talking about PCMH and team-based care, where we are collaborating with the different sets of providers. So it would be ancillary service provider, nursing homes, hospitals, hospice, and so forth. This is very similar to that, if not exactly the same, but to ensure that all of these people are working together. The thing is that what is the initiative? Is there an initiative taken by the hospital and spread across the community, or this initiative is taken by a nursing home and spread across the community? So there needs to be the best example I can give is sort of a community level open table where all the stakeholders come in and decide that when it comes to palliative care, this is what we are going to participate in. We are aware about it, and we'll go ahead and ensure that we can help the patient in the best possible manner at all levels of setting.
Thank you for sharing that. Great. I would like to ask the entire panel one question before we open up the floor for questions and answers from the audience. Oftentimes, as a former director of social services and a mental health case manager, we are often asked by patients and family members if they have to be in a hospital to receive palliative care. Can you guys expand on that a little bit?
You don't need to be in hospital to actually get palliative care services, as we spoke about, in one of the slides, we spoke about how palliative care spans across the continuum. So it's provided in home settings, provided in hospital settings, inpatient settings. There are specialty clinics that provide it. The specialty clinics that could be freestanding, they could be embedded in a host clinic. So it depends on the patient's goals. So every service that palliative provides has to patient and family in the center of the service. So it is basically a patient's choice, what they feel most comfortable with. And like in the case study that we illustrated before, that in particular individual, because her diagnosis was so complicated, required an inpatient palliative care. So that is a possibility that at some point your physician or your healthcare team will advise you that inpatient setting is more appropriate for your diagnosis. But in most cases, it can be effectively provided in home setting or whichever setting that the patient and family are more comfortable with.
I would just like to add to what Dr. Mangat mentioned that definitely hospital is not necessary in terms of you have to be hospitalized to have palliative care. In fact, one of the newer thought process or relatively newer thought process has been that if there are certain things which we can do it as home shoring or ensuring that the patient is home and can be provided as home care, that turns out to be a very good setting, especially with the caregiver's comfort zone also, keeping in mind that this program is about family and patient-centered.
Thank you, Dr. Parikh. Now we would like to open up the floor for questions and answers from the attendees. On the left-hand side of the webinar platform screen is a text box to write questions to the presenters. If you have a general question, please insert your question into the text box. And if you have a specific question for one of the presenters that you would like to ask, insert his or her name next to your question. At the end of the webinar today, you'll be directed to a short survey, which the healthcare executive hopes you will take the time to fill out in future programming event. So the first question that comes from the audience is, what is the difference between don't know and not at all knowledgeable? Dr. Parikh, I believe that was geared towards a portion of your presentation.
So the two parts to it is that when you say don't know is that there are people where we've heard from the system, especially from the hospital side, who say, I just don't know what palliative care is. It's like a brand new thing to them for different locations. When I'm saying less knowledgeable is they've heard about palliative care, somebody from the setting has reached out, either to the patient or the caregiver. They do not have the complete understanding and the holistic picture as to how it works, what are the advantages, and due to that lack of knowledge, more than likely tilt toward the answer of saying that no, I don't want to go ahead and participate in this, or I don't want my uncle or aunt or father or mother to be part of this. So that's the difference between don't know is pretty much like zero, where you're introducing that thought or telling them about palliative care, versus less knowledgeable is that they have very limited idea and understanding about this particular care.
And this is a general question. What can we do for palliative care in relationship to outpatient setting?
So some part of it is really understanding how your outpatient setting services are provided. Are they provided? Do you have an outpatient center which is freestanding? For example, if your care is geared towards a specific diagnosis such as cancer, or if you have a palliative care outpatient setting which is basically subsidized by a hospital or health system, often with sort of some kind of expectation that you are going to help the health system reduce those unnecessary visits and length of stays and emergency services. So it really depends on what your setting is, what your organization's needs are. But the principles really stay the same. You would still need to span those 8 domains of palliative care and make sure that you are providing your population with all the resources that you have, and possibly also training your staff and training your physicians and training your nurse practitioners to be specialists in palliative care, because we do know that traditional medical care does differ from palliative care. The focus is different, and to make sure that it is communicated through the practice what it means to be a palliative care outpatient center.
And this is just a general question. Are pain management services a component of a palliative care program?
So they are. They absolutely are. So they fall in 8 domains, which we spoke about: the physical aspects of care, pain and other symptoms, which are dyspnea, fatigue, or medications. They are managed using the best practices that are provided in a palliative care program. However, some organizations do have pain management as a separate component. They have pain management services, but they don't necessarily have a palliative care program, which is when the palliative care can basically supplement that kind of branch.
One other question that's also general is, I work in public health systems where resources and access is limited. How do we engage our providers in being the palliative care facilitator?
One of the things which I may mention is that it is going to be right now what we've started doing in some of the systems is that we're like any other program, we are developing physician champions basically for palliative care who are going to go ahead and lead the cause and engage not only the other providers but the staff also. And there is a certain time commitment needed for that, especially initially when we are designing the program. So that has what has been the approach, is to go ahead and have a physician champion who would be working on palliative care paradigm.
So I would just add to that, there are special training programs that some organizations are developing or getting specialty training programs from other organizations who are expertise in training and development of education. But the part where we always, end up in trouble is where physicians and the medical staff that you have that are not palliative trained, they have concerns. They have concerns about palliative care, what it means to their practice, what it means to them in terms of payment structure. All that confusion really is the biggest barrier in terms of implementation. So if we can have clear channels of communication, if we can provide education on what it means to them and why we are doing it, so the why, if we can explain the why, we will certainly have more success.
Dr. Mandeep, this question is for you. Can you talk further about the insurers providing capitated payments for palliative care?
The payment system at this time for palliative care is a bit complicated because it kind of varies. It does vary, and so in terms of hospice, we do have a standardized, a packaged model there. Our services are, provided, and eligibility criteria is defined by insurance benefits and federal programs like Medicare, Medicaid, and Veterans Affairs. Whereas palliative care, the hospitals, they usually really bill for inpatient days under traditional Medicare and Medicaid or commercial insurances. And some of the insurances go ahead and create some kind of bundled payment for palliative care, just like we see bundled payments in terms of BPCA models. They have some sort of bundled payment for palliative care as a supplemental care or as a continuum of care. And physicians bill for palliative care consultation services under Medicare Part B and commercial insurance. For most part, most of the organizations would end up directly funding a palliative care program. They would end up funding that program, or the ACO, if you are really linked with an accountable care organization, then that accountable care organization might be able to come up with a bundle payment specifically for your organization. And we have seen a vast variety of payment structures out there. Some commercial insurers would provide you payment for offering palliative care services, would want to partner with you to come up with a program in advance. So it really varies at this point. If we had more clarity on payment models, I think we would also have more uptake of palliative care services.
And this is a general question for the panel. Could you suggest additional information related to prenatal palliative care?
Happy to share a couple of resources. Sorry.
Another question would be, in addition to providers, are there opportunities for other members of the healthcare team such as the nursing, social work, or in the primary care setting to support patients who are in need of palliative care services? And if so, are there best practices?
So there are absolutely opportunities for members of care team. Obviously, palliative is an interdisciplinary both physician is one part of the team, but then there is nursing, social work, chaplaincy, rehabilitation, therapy, a lot of services that come together to basically support the patients. And there are a lot of best practices, and if you want to go into depth of what those best practices are, I would again cite the CAPC, resources, educational resources that really provide a great deal of information as to what are the best practices in terms of palliative care program development, as well as the roles and responsibilities of each team member in that care team.
And this is a general question. I work in the intellectual disabilities industry. How do we provide palliative care in this industry? What resources are available?
So I would take that up, Greg. So I believe that anytime we have an advanced illness, so in terms of intellectual disability, if we have an advanced illness and we think that in terms of prognosis, this advanced illness is going to go on for years to come, we can certainly provide palliative care services. Now, the palliative care services might have to be really customized to this patient population. And there are a lot of resources that I can cite. If you go to NIH.gov, they do have certain great research studies on patients with intellectual disabilities. And because the life expectancy of people with intellectual disabilities has increased dramatically during the last century, there is a lot more research at this point in terms of palliative care and its usage in this population than we had before.
One other question is there a move to obtain palliative care payment for Medicare as CMS payment transitions away from a fee-for-service to a value-based payment model? How do you expect palliative care to be effective?
So I can take that on, Greg. So we, in our organization, for example, there are tons of Medicare demonstration projects at this point ongoing in various parts of the country. One of them is Medicare Care Choices model, which basically provides you some kind of payment per member per month for participating in a care model, which looks very similar to palliative care. It's very focused on consultations and very focused on care coordination, the core components of palliative care. And they're testing all these models in various parts of the country, and we are involved in one. And basically, after these demonstration projects basically come to conclusion, and after they take into account all the data and metrics that they're getting from these projects, I believe they're going to come up with a better payment model. For MCCM, I believe it's $300 per patient per month at this point. And I think we will have more clarity over the payment structure in the coming years.
Why would my healthcare practitioner suggest that I get palliative care?
So the healthcare practitioner, I will go back to the case study that I went through. There are times that our traditional medical care is just not working. We see the same patient again and again, hospitalized twice in the last 4 months. We see them again and again in ED. We know that there are other aspects of their care which need more attention. For example, social aspects, psychological aspects, family, caregiver, the structure of the help that the patient is getting at home. So at that point, because we realize the limitations that traditional medicine has, we might say that this patient can benefit from palliative care because palliative care is specifically for advanced illness patients who need an extra layer of support on top of the traditional medicine. So we're not taking away the curative, aggressive treatments, but we are adding another layer of social support. We are adding another layer of pain management, symptom management, aggressive approach to defining the goals of care with the patient in the center, with the patient deciding what their goals need to be.
Dr. Mandeep, do the Palliative Care Information Act and the Palliative Care Access Act apply to children?
Yes, it does. And these acts are really in New York, right? So the Palliative Care Access Act and Palliative Care Information Act, which basically took effect on February 1st, 2011, it really requires physicians and nurse practitioners to offer information and counseling about palliative care to patients with a terminal illness. So Palliative Care Access Act basically builds upon the Information Act, and it applies directly to various facilities and agencies and individual practitioners as well. Again, it applies to all the patients, including children with advanced life-limiting conditions, or all those who are not terminally ill. So they offer information, they offer counseling services, and they basically help facilitate access to palliative care service.
And that was the last question on the platform. On the left-hand side of the webinar platform screen is a text box to write a question to the presenters. If you have a general question, please insert your question into the text box. If you have a specific question for one of the presenters that you would like to ask, please insert his or her name next to your question. One question that came across the platform is, how often do you have patients refuse palliative care?
What we are seeing is that in the different regions, depending on, as we were mentioning, that based upon the fact that the setting is offering palliative care, there is a physician champion who's taken some training, attended the courses, has engaged the staff. I think has a lot to do with the fact that how it has been articulated with the patient. How often do we see it? At least for 30 to 40% of the time, at least in our area, in different regions, if I can just say mix and match, about 30 to 40% of the time, the initial answer is that no, we don't want to do palliative care. And probably a year and a half ago, we were at a rate where it was probably 60-70%, and the reasoning to deny was the lack of understanding and knowledge as to what is done. And as we know that the payment models are not clear and there is a certain cost allocated to the system. But from the patient's point of view, if there was anything which was coming across as additional payment, they wanted to go ahead and they were saying absolutely no for that and moving ahead with it. So that is what has been our finding in this region.
Dr. Mandeep, did you have anything to add to that?
Oh, I really agree. So sometimes the patients who refuse to see the palliative care team, they really worry that doctors are giving up on them or sending them home to die. So it's really listening to the patients as to what they want and trying to help them get the most out of their life. Trying to help them understand their diagnosis. Sometimes it's a sheer denial. A lot of times we see a sheer denial where they don't want you to stop trying. They don't want you to stop the aggressive treatment. They don't want to. They're not prepared at that point. And so just having those discussions, and because palliative care teams are so skilled in communication, which the regular teams are usually not, because this is not a skill that was provided to us in our medical school or nursing school training programs. And this is a skill that is incredibly critical to a palliative specialist. They are able to talk to the patients in a better way, and they are able to describe and explain the diagnosis and implications, and they're always also able to assure the patient that curative treatment will not be taken away from them. It will still be provided, but they get more. They get more services in addition to what they're getting right now.
One other question is, in today's changing landscape, missing or inadequate primary care infrastructure is a significant challenge. What are your suggestions for strategically developing programs like palliative care, and is it not more of an element of care coordination?
Part of this is that when we are looking at the primary care infrastructure and couple of programs like ACOs, PCMH, where we are trying to work and have a collaborative approach, coordination of care across the continuum. I think palliative care is a crucial piece which we need to really go ahead and get it in forefront and address it with the rigor which we need to. And I think it is happening, but it is slower. We do need a little bit more backing from the policymakers in order to really gain further or additional traction. But from a organizational point of view, when it is coming to the fact that we are getting into the value-based care delivery system and the way we are addressing some of these issues through different initiatives, it has been helpful, and palliative care has gained traction rightfully, especially in ACO setting. In order for us to really go ahead and develop more programs, I think a formalized structure is needed, and most importantly, there has to be a division where a person has quote-unquote taken a formal training for palliative care and has built a team in that aspect, which is going to go ahead and work with other stakeholders or other parties from that division as well as the external along with the external stakeholders to really go ahead and form the holistic approach of palliative care.
Should these palliative care teams be implemented in organizations that don't currently provide them, or should these roles be incorporated into their current care team's infrastructure?
Taking a part and part approach, that means that some places there's been a possibility in terms of logistics, manpower, and economics. We've been able to go ahead and create a brand new team depending on the market requirements. In certain areas, we've been able to go ahead and have a sort of hybrid approach. A de novo team with a very clear focus usually works better, but may not fit in the scale of economy. So that's why both the approaches have been tried or have been dealt with, and they work equally good depending on the requirements of the market.
So I'll just add on to that. I agree with Dr. Parikh that if you have a focus on palliative care, and if this is in fact provided as a service, as a separate service, it has the potential to then demonstrate increase in patient family satisfaction, improved quality, which we have seen through many studies, and cost savings as well. So a lot of times when we talk to organizations and individuals who are offering something that they think is palliative care, is the realization that the traditional team, although they think, when they look at palliative care, they think, I think I have all those things that I need to create a palliative care team. They actually don't, because palliative care does include traditional medical care. In fact, it has all the curative treatment and aggressive treatment modalities in it. But it's different. It's different, and that difference is not clear to the traditional teams. So if we are able to communicate, and if we are able to educate and train individuals to be specialists, palliative care specialists, and it's not a field for everyone. Every clinician and every healthcare team member does not want to be a palliative care team member, because it requires people with certain skills, certain communication skills. It requires a greater level of empathy, and it is difficult on a personal level for many staff members. So those are all the considerations that you need to take into account before you think of blended form of providing palliative care services versus having a team which is dedicated to be that resource.
Thank you, Dr. Mangat. As we wrap up today's course, we would like to especially thank today's moderator, Greg Wahlstrom, Dr. Mandeep Mangat, Dr. Vicky, Parikh, for taking the time to share pertinent information about population health management with a focus on palliative care and the impact it has on each of our organizations. We are happy to announce the Healthcare Executive Forum of the Idaho ACHE chapter and the Central Illinois chapter of the American College of Healthcare Executives We'll be holding a webinar on Wednesday, February 3rd, 2016 on strategic marketing, winning the battle for markets and shares. And the healthcare executive will be holding a webinar the following week on Tuesday, February 9th, 2016 on healthcare executive leadership, improving communication and leadership in high-stress environments, worth 1.5 hours of qualified education credit through the American College of Healthcare Executives towards your board certification or BREED certification. Please feel free to connect with us across these social media platforms. And if you have any questions or comments, please feel free to contact us at the contact information below. And we would like to thank each and every one of you for taking the time out of your busy day to attend today's webinar. Make sure you log into your ACHE account to record your 1.5 hours of qualified education credit for today's webinar. And this will conclude today's webinar.